Hello, good evening. Welcome to episode number 3 of the patient educational series IECO sponsored on dry eye. And I'm so excited to be here tonight. I know this is what you guys have been waiting for. Hopefully you've joined us for episode 1 and episode 2. Tonight we have the distinguished panel is back. I'm so excited to have all 4 of our dry eye experts with us. First of all, I guess I should introduce myself. For those of you who don't know me, I'm Suzanne Paulson. I'm the CEO and the founder of IECO. With me tonight are 4 brilliant minds of dry eye. Dr. Laura Perriman, an ophthalmologist from up in the Northwest. Brilliant! And fabulous to have you back again. Dr. Leslie Odell, another brilliant optometrist who's over in the East Coast. You guys are on East Coast time. Laura and I, Dr. Perriman and I are benefiting West Coast. Dr. Amy Now, again in Boston, there she is, and she's part of course, the Corbin Associates, partner Corbin Associates. And then we have Dr. Crystal Brimer, who is with us, and she's in North Carolina. And also on the East Coast, thank you so much, founder of the Dry Eye Institute, and of course, Leslie, MOA Queen. So I have so much to cover tonight. I'm not going to go into a lot of detail. That's our beautiful panel. Tonight is all about, we did episode 1, causes and symptoms of dry eye. Episode 2 was diagnostic tools and why that matters and why going to see your eye doctor matters, to understand why these things go through that process so that the doctor can truly diagnose what type of dry eye, what the causes are, and what that allows you to have a customized treatment plan. Tonight is all about the treatment plan. And there's going to be 2 sections to this. The first one is kind of the menu of options, things that are available, and they're going to be in 3 sections. The first one is managing eyelid health. The second one is managing ocular surface wellness. And the third one is managing the physiological side of it. Now, both of these have 2 parts, because what we've learned in this paradigm shift, which is really the theme, is that there's so much that doctors can do in office for you, but what you do as a patient at home is equally important to manage those symptoms. So it's how you marry those 2 that will bring you the highest and the highest quality of life that you can have, the highest and best life. So we're going to kick it off tonight with the eyelid health. I'm going to just briefly go through, for those of you that didn't see episode 1 and 2, please go back. These are all recorded. You can take a look at it. But obviously, this is a very big topic, over 75 causes and symptoms of dry eye. So when we look at managing eyelid health, we're going to say, what can you do at home and why is this so important? And I'm going to let Dr. Odell and Dr. Brimer kind of kick this one off. And this whole evening is about a panel discussion. So first half is all this stuff. What are the menu options? And then the second half of this episode is all about how we're going to marry all these different tools that you have at home or in office to what is important to you after you've been diagnosed. Dr. Odell, do you mind taking this over?
No, I'd love to. And thank you again so much for including me. This has been such a fun series to be part of, and it's always great to be on a panel with the rest of the group. So it should be a fun night of conversation and helping to educate people as to how best to treat them, their dry eye disease at home. And so with that, I am going to switch this slide and let Dr. Brimer take over. Dr. Brimer, sorry.
Sure. Actually, you go back a slide, Leslie?
Sure thing.
I'm going to back you up, because before we get to that section, there's these other areas that I think are important for the audience to know about managing. So the compress is one, but also lid cleansing, the blinking,
okay,
full compressing.
Yep. We'll touch it on it all.
Thank you.
So let's talk about that. Eyelid health is so much more than cleaning. But to take that as the first section, cleaning is the foundation of it all, because bacteria causes so many other cascades of issues. So that could be as simple as a scrub or an eye wash. I absolutely love my IECO products. I use the anti-aging one, and I use it every day in the shower. I tell patients, put 1 pump on your fingers, rub it together, go over your lashes, and then go over the whole face. So we can do that. That's an absolutely fabulous go-to for everybody. But then sometimes we need additional cleansers and products to help with other kinds of bacteria, like if there's a film on the lid margin. And that's when a lot of times I'll use hypochlorous acid products, where they can put it right on that lid margin. It's okay if it gets in the eye. And then there's an even more kind of aggressive manner, where we actually have an at-home device called New Lids that exfoliates the lid margin. So there's lots of different ways to clean the lid at home, but that's an essential part. And the soap that you use for your face and your skin and your hair is not necessarily the right soap for the eyelashes and the lid skin and how sensitive it is. As far as eyelid health and just keeping the functionality the way it should be, we need good closure and we need clean lids and we need good oil flow once you do close those lids together in a blink. So what we find a lot of times is that folks that are at the devices all day long, and especially now with the mask on and they've got this air pushed up to their eyes and they're staring at the device, the blink is one of the weak links, because if they're not blinking fully and those lids aren't touching completely, it's not milking those glands. And we're going to talk a lot about how to nurture those glands and get more oil out. But the blink is a key part of it. When I'm talking to a patient about how to do blink exercises, I'll tell them, close your eyes and then pulsate. So go through the motions of that blink, but don't open back up between blinks. And I'll ask them to do that with whatever is repetitive in their world. So if they watch TV all day, every commercial. If they drive all day, every stoplight. At the computer all day, whatever it is they're doing, every website, every data entry point. I'll use cold compresses when somebody has an issue of puffiness, allergy eyes, they wake up swollen. I can put that green pod in that Tranquilize XL mask and it'll calm them down just in a matter of 2 or 3 minutes. And then on the heat side, that's going back to trying to get the oil glands moving. And there's a long discussion we can have about differences between warm compresses and what the benefit is. So I want to get into that, but to give you kind of the goal behind it, when we've got stagnant oil glands, it's all about thinning out the oil and getting it moving. Thinning out, getting moving. So the thinning out is more about systemic things that we'll do regards with diet and other things, but getting it moving, that's where the heat comes in. That's where massage comes in at home, and then we'll talk later about in-office ways of getting it moving. So let's look at what makes a difference between all these warm compresses that are on the market. It really does matter what the temperature is and how long it stays hot. You know, I want a patient to have at least 10 minutes of high constant temperature, but it's not just about the temperature, it's about the moisture, because I need that penetration through the lid. Because when you think about it, you know, the lid is, I always say it's beautifully and wonderfully made, right? Which means it was made to wick heat. So it was made to protect that cornea underneath it. So when heat comes, it's supposed to keep it from penetrating, which means we've got to be pretty crafty if we want the heat to be externally applied and penetrate through the lid. So it's really about having the right combination of moisture and temperature and duration in order to thin out that oil and get it moving. So Leslie and I were part of, Dr. Adele, we were part of a study where we compared different warm compress techniques. And Leslie, show us the details on that and what a difference it made.
Just like you said, that duration and moist heat is so important when we're trying to thin out the meibomian glands. And so what we were able to do was take a look at some of the science, you know, using some of these great products that iEco has, just to see, you know, how can we do an in-office treatment and then carry on with that at home, and what effect was it going to have on signs and symptoms for our patients with dry eye disease and meibomian gland dysfunction. So this study was put together and done across 4 sites. And so we both were part of that, which was a very exciting time. And so what we wanted to do was look at controlled heat at home following an in-office heat. So what we did was heat the patient for 15 to 20 minutes with the tranquil vibes. So not only heating the meibomian glands, but also using this vibration around the orbital rim. And then we did a manual expression during that visit. And then the patient was sent home either with the Tranquilize XL mask or a Tranquil Vibes mask, unbeknownst to myself or you. And then what we did was see them back in about a month to look to see if our metrics had changed. And the patient was instructed to use that heat mask for 20 minutes a day in between our visits back. And so on average, we had we had 35 adults. They were about 60 years old, and there was these 2 study visits. So our initial visit and then a month after. And it turned out that between the mask, the masked distribution of the products, we had 19 patients that had the vibration and heat with Tranquil Vibes, and we had 16 patients that had at-home heat alone with the Tranquil Eyes XL mask. And again, they were asked to heat daily for 20 minutes and to keep a logbook of that, so we were sure that they did that. A couple of the things that we looked at, which were really, was a very good result on both sides for Tranquil Vibes and Tranquil Eyes XL. We looked at signs and we looked at symptoms. So when we looked at symptoms, we used 2 of the validated questionnaires. We looked at symptoms using SPEED and DEQ5. If you look at these graphs on the bottom left-hand side of this slide, you see the Tranquil Vibes group listed first and the Tranquil Eyes XL group listed second. The first blue bar is our baseline symptom score. So you can see actually that if you look at, the taller of the 4 on this bar graph, we had pretty equal symptoms in both groups, the Tranquil Vibes and the Tranquil Eyes, but we did get significant improvement of symptoms. So if you look at the vibe, so the mask with the vibration, we had the SPEED improving 35% and the DEQ5 improving 37%. So over a third of patients had improved symptoms using the Vibes mask, but we also actually had a nice improvement in symptoms using the XL mask, so just the sustained heat without vibration. I always like to see what kind of clinical endpoint can we have. Our goal is to make you feel better, but sometimes the feeling better happens even after you start looking better. And so for our metric for this, we use the tear breakup time, so how quickly your tears evaporate. That's a very important metric when we're looking at stability of your tears, and a lot of times this is used in clinical research. As you can imagine, the more stable your tear film is, the less blurry your vision will be throughout a day, the less symptoms you're going to have, such as burning and such. And so we want to see that in an ideal patient. We like to see that tear breakup time to be about 10 seconds or less. So that means no dry spots show up on the surface of your eye for about 10 seconds after you take an initial blink, hold your eye open until that second blink. A lot of times, though, in our dry eye patients, this can be almost an instantaneous finding. Sometimes I'm evaluating tear breakup time, a patient blinks, and they not only have 1 dry spot, but 10 dry spots immediately upon opening their eye because the tear film's so unstable. So to improve that is challenging, and it is exciting to see when we can do that. So in this case, we were able to improve the tear breakup time statistically significant in our Vibes group, so the heat with vibration, but we also had improvement of that tear film stability measured through tear breakup time in the Tranquil Eyes XL group. So, I just wanted to see if you had anything to add, Dr. Brimer, just because I know you also were one of the investigators here, and, I didn't know if there was anything you wanted to add to that.
I think one thing to add is just the experience. So many times our dry eye patients, they're miserable by the time they get to us, and they've tried so many things. And so not only am I going for, all right, I need that tear film to be more durable and not break up as quickly and really do better for the patient over the long haul, I want to give them some relief immediately. And I'll say, experience and feedback from the patient was phenomenal, but especially with the vibrating, the Tranquil Vibes. So ultimately, it's basically the same mask. It's just that one vibrates and one doesn't. So I've always had patients love the Tranquil Eyes mask, but to have that vibration on top of it, they just unanimously thought it was so relaxing. And, we'll talk later about stress and other things that compound dry eye. But to give them 20 minutes a day where they're completely relaxed and they take it off and say, boy, I feel better, and to know that we've got long-term relief coming from the act of doing that consistently, it's just, again, nice to be able to offer that to the patient.
Yeah, and even being able to do that treatment ahead of sending them home with something, they all got the experience of the Tranquil Vibes mask because that's how we did the manual expression. I feel like there was a little bit of disappointment if they didn't get that mask on the way out the door.
I was disappointed for them.
Yeah.
Like, oh, come on. And I didn't even know until they came back, but still I was rooting for them.
Yeah, I know. I felt the same way.
And I would think, Lizzie, let's open it up to you guys too, Dr. Now, Dr. Perryman, because I think we all have our own go-to and our own favorite on our heat mask. And just tonight, I was doing a telemedicine consult with a doctor in California, and I was just bragging about how much I love my Tranquil Eyes XL because of the penetration, the duration, the consistency. That's my go-to. But what do you guys go to?
So I love the Tranquil Eyes XL. I think 2 points I want to make on this is when you have something that does it the right way, instead of just a towel or a face cloth that you keep putting under the faucet, it makes a huge difference. It's easier and the compliance is better, and it's just a better experience and a better outcome. But for patients who have certain things like a corneal transplant, keratoconus, my go-to is the iCloud because you can make a little bit of space between the mask and the eye if there's a situation where you don't want to be pressing on the cornea. So I like the iCloud for certain patients a little bit better.
Makes sense. And you send it home with them?
Well, yeah, I mean, so it's hard for us to keep this in stock, actually. So we do when we can, but if not, then we just give people the website and they could buy it on the website.
Gotcha. What about you, Dr. Perryman?
Well, as a fellow dry sufferer and also MGD sufferer, I've tried all of these and I use all of them. I like all of them. They're fabulous. It's great to have little demos in your clinic to show them.
Yes.
And they're all fantastic. I use the clouds for some of my children with chalasia that come in. They just seem to like the cool goggle effect, and there's less chance of it, getting askew on their face. So I reach for that one for the kiddos. And the vibes I really like, if there's any kind of Demodex involvement, the little mites that live on your eyelids don't like vibration. And so whatever I can do to disrupt those little buggers, I'm all in favor of.
Good point. I had somebody today come in and she said, I do warm compresses. And she told me she did it 2 or 3 times a day. So I knew it was a short duration. I said, well, what do you use? And she said, I use the rice and the hose, because I Googled it and I looked into that and I thought, well, she's trying. She went out there and it's better than a hot rag because it's just impossible to keep the rag hot enough, long enough. And it's just going to be a wasted effort. And like you said, Dr. Now, it's about compliance. The easier I can make this, the more consistent they're going to be day after day. And that's the only way to get results. And I'll sit and I'll talk to a patient. I rarely use the derm mask because I know the Tranquil Eyes is going to be so much more effective. But the only time I will is I'll say, listen, this is exponentially better, hands down. However, if you're not going to do this, you're not going to make the time to do 20 minutes a day, then it's going to do nothing for you. So in that case, I'd rather give you the 5-minute mask and know that you're going to do it every day. So I think that's a great point, and it's something that as a patient, you guys really need to kind of fess up and say, what am I willing to do? Because it's all about consistency when we want to get real results with dry eye.
And I can't emphasize the safety component enough to the point that my colleagues have spoken about, that the warm, wet washcloth not only has wild variations in temperature, and you don't have that consistency of heat to create the melting that we need. I have seen many, many cases of significant dermatitis just from the cloth being too hot, from the constant wet to dry action. This is moist, not wet. And so I think that's an important distinction that helps keep the skin intact, the skin healthy, prevents dermatitis, skin breakdown, potential burns from a cloth that's too hot, etc. So this is a much safer, even keel, effective way to go about it.
Yeah.
And just getting back to safety real quick, when you think about the rice in the sock, or, when I first started doing treatments, I mean, when I first started learning about meibomian gland dysfunction, where I was working did not have products like this. And so, some of the lectures even are just crazy to me now to think about, boiling an egg and putting it on your eye, or like a potato, right? Like just to get sustained heat there. So thank goodness we have these products that are safe, and can give us sustained heat for, up to 20 minutes, which is, amazing for patients, and safe again.
No egg on the face and no Mr. Potato Head.
I know. We've come a long way. We've come a long way. So, but sometimes you might run across that when you're doing these Google searches, even still to see the rice in the sock as what you've found when you're doing a Google search, much like the baby shampoo for lid hygiene, it might still be out there, but it doesn't mean that it's the best way. And these masks are definitely regulated and safe, which is so important.
Dr. Odell, you just answered a question, or touched on a question that came in from the audience, and we are going to be taking questions at the very end because there's a lot to cover, but it was on baby shampoo and whether or not you should use baby shampoo to clean your lids. Does anybody want to comment on that real quick? You want to expand on that?
Yeah, I'll take that one.
Thank you, Dr. Krim.
So baby shampoo is an old way of cleaning the lids. The bummer part about baby shampoo is it's not so safe and gentle for use around the eyes, especially long term. The surfactants that are used in baby shampoo are much too harsh for the delicate meibum, and your poor little meibomian glands have been slaving all day long, all night long to create meibum. You don't want to overstrip those delicate oils. You can lose those really protective oils that are so critical and actually exacerbate your problem. Furthermore, there's preservatives in many baby shampoo type products that contribute to corneal nerve irritation and contribute to damage to the ocular surface. And those are namely the formaldehyde donating preservatives, and you really want to avoid those.
Super. This is going to launch us into perfect segue to there's all these wonderful options now for at home, for managing the eyelid health, and for in office. Holy moly, we see an explosive growth in this area too, is of different treatments that are available for patients in office to manage the eyelid health. Do you want to continue, you and Dr. Now, to go into some of these different tools that are available for treatments?
Yeah, I guess I would just like to tell the people who are watching is that some of these things seem like they're very complicated. Patients get a little bit scared about trying some of them. Sometimes they're a bit expensive, but generally everything is it's a little bit like a spa treatment for your eyes. It's a deep cleaning procedure. And, there's many ways to skin a cat. I'm sure that if you went to several different dentists, they might have slightly different instruments to clean your teeth, but they're all doing the same thing. And if you, as a patient, if you really think about this as, home therapy, most of the time with episodic deep cleaning, starting at an early age, like this would just become a routine thing. Sometimes when people have entrenched disease, you need to do it more often, or you need LipiFlow plus Ilex or LipiFlow plus IPL. You need these different things, but they shouldn't be scary and they don't hurt. Most patients find that they're quite relaxing, actually. I don't know if you have a similar experience, Laura.
For sure. Patient, especially when it comes to the in-office cleaning, we'll do the deep cleaning. We do a lot of microbuffer exfoliation with AV Max and also with Zest, and then we follow up with their home care. But I love it when patients go, "Oh my gosh, my eyes feel so clean and so good," but it's clean in a good way, not in an overstripped bleach way. It's in a very healthy way.
Right. So there's lots of different ones. You can argue the merits, and that's all still being worked out. But I think just understanding that you can sometimes only get so far with things that you do at home. Just like you brush and floss your teeth, but tartar still builds up, and you're going to get biofilms between the lashes. Your meibomian glands are going to get clogged from makeup or using the computer too much. And sometimes you just need a little extra, little oomph that we can give you in the office.
We talked about the dental model before, where you go in twice a year to get your teeth deep cleaned. And the same is true for a lot of our dry eye patients. We really need to get in there twice a year and do the maintenance work. Brush and floss only the teeth you want to keep. Do your your home maintenance programs on the meibomian glands you want to keep, but come in for those regular deep maintenance measures.
Anything else you want to expand on meibomian gland dysfunction? I know we're going to get into how you can treat these things later based on what your diagnosis is for the antibiotics, surgical repair, any of this eyelid help that would be in office.
What I would say just from a patient perspective is, I would almost ask your doctor what the status of your meibomian glands are, because there are still, we might be overlooking it if we don't know that you think that you could have a problem there. And so I feel like, you're armed with a lot of knowledge now when it comes to being a dry eye patient, and asking your doctor these questions, I think will only help you, in your care long term. And so a lot of times if I have a patient that is calling in for me to do another evaluation, that's one of my first questions is, what's the status of your meibomian glands? Have you been told that? And I think that if you can be proactive with the providers that you're seeing, that will help for sure.
That's great. Okay, super.
I'd like to make a quick comment about antibiotics and surgical repair. So the antibiotics is very interesting. I'm not a proponent of oral antibiotics for blepharitis. It creates too much impact on the gut flora and doesn't get to where the problem is, which is here. So there's a role for topical antibiotics, topical cleaning agents that help to reduce the amount of bacteria. But it turns out that this paper was just published today, that the flora, the bacteria around the eyelids of a Demodex patient is different than that of a normal patient. And so there's definitely this microbial component that we can address with our deep cleaning. Our IPL actually has an antibacterial effect. Our antibiotics, such as combination antibiotic steroid medications. And then finally, surgical repair. If there's a significant defect in the way the lid is performing, either not holding the tears in, that's called ectropion, or if it's folded in and rubbing on the eye, that's called entropion. Those are actual surgical problems that have to be addressed mechanically. Even lid laxity can be addressed with technologies such as radiofrequency therapy. So it's important to look at the actual physical performance of the lids as well as the meibomian glands. And in fact, I'd like to ask this to my colleagues. Have you observed, like, some of your patients that have weakness in the lateral canthal tendon and the lid's just kind of sitting there? Have you noticed that those patients in particular have more MGD than patients that have normal tone on their lid? Have you appreciated that? And I have to wonder if it's just because it's not on stretch, right? The canthal tendon is here, and that lid is on stretch. And if you lose one end of it, how are you going to squeeze against something that's limp?
Right. That's so true. I mean, we talk about that all the time, where we actually send people for eyelid surgery because we say, why are we going to rehabilitate the glands if they can't blink normally? They're just going to clog up again. So I'm glad you brought that up. I think it's true.
Okay, we're moving on to our next section, which is going to be them. I wish we had hours. We don't, I know. There's a lot to cover. So we're going to go on to managing the ocular surface wellness at home. And there are some things, we have lots of questions from the audience about how they're waking up and what they can do to increase their comfort when they're waking up in the morning, things that are going on, what can they do about ointments, when do you use ointments, what about artificial tears, a lot of questions about preservative versus not preservative. So I'm going to kick Dr. Odell. Do you mind working with the panel on this one, this big old topic of managing ocular surface wellness at home?
For sure. So again, a lot of what is happening with dry eye disease is not only done in our offices, and with eye drops that you would be using, but also what you are doing at home. So a big part of success in outcomes is adding this at-home care to a patient's treatment, if you will. So this looks a lot of different ways. When I look at this slide in particular, I'm going to actually jump to the bottom and talk about daytime moisture chamber glasses. And I'd love to hear the take from the rest of the panel on their recommendations here. So this is, if you look at some of the guidelines that we as the doctors use to treat patients, this is always listed in that first modified list, whether, you know, along with artificial tears are the moisture chamber glasses. And, you know, personally for me, I have a more of a challenge getting patients to wear these, but the theory of them and the concept of them, I think, is really amazing. And so I just wanted to see where the group was on recommending these moisture chamber glasses and what success they've been having with patients with them at home.
I have good success with them as sunglasses. So we live at the beach and it's humid, but yet we still have abundant dry eye. And I have patients who want to be outside, they want to garden, or they want to walk on the beach, or this and that, and they just can't because it's debilitating for them. So this is perfect for that. They're able to basically run water over that little chamber, click it into the temples, and it's like an internal humidifier. And there's a gasket on the inside of that frame that keeps a lot of wind and ambient air from getting onto the ocular surface. It's not meant to seal the way that like swim goggles would be, because then it would fog up, but it's meant to inhibit some of the more aggressive airflow. So I love it for sunglasses, and I have great uptake for that. It's a little hard when it's clear because the frames are so bold that with the clear lenses, aesthetically, I get a little pushback there.
I think, well, we have really good luck with them. And, you know, for a patient to try to understand why we like these, when your tears break up, and Dr. Odell was talking about that study where they looked at tear breakup time. When your tears break up quickly before you get a chance to blink again, it means that your corneal nerves are exposed to air. And when that happens, they get irritated and they become very sensitive, and it's hard to calm them down. And so if you can prevent the tears from evaporating by making a little humidity chamber around your eyes, you're protecting the cornea. And it's by protecting the cornea that you can decrease some of the inflammation on there, and it makes you feel better. So that's the whole point that we're trying to do. And I think, I mean, I would go to these way before Sclera Lenses. You know, they're inexpensive. You can take them off and on really easily. Sometimes they look a little goofy, but they work really well.
Dr. Perryman, do you have anything to add on that topic before we move to another?
I love the chambers. It's, you know, not only light control and wind control, but also allergen control. Mm-hmm. We have big allergy seasons in Seattle, namely the spring and the fall. Finally starting to get on the tail end of some of that, but that all the allergen gets kicked up in the air and in the wind, so you get a third layer of protection with use of these devices as well. We keep the nighttime, I'm a huge fan of the nighttime goggles. We do a very simple test where we take a small muscle light and shine it right at the sulcus pointing at the interpalpebral fissure. And if you see light escaping under the door, so to speak, between the lids, that's an inefficient lid seal. And this is work done out of Dr. Korb's office, but that is my call to action to prescribe these silicone night sleeping masks. And they're wonderfully soft, and they're so well made that you can sleep on your side. And a lot of people have a sleep side preference, and you can tell on exam. Sometimes it's subtle, where you've got one side that has a little bit of an allergic response going on, or more meibomian gland dropout, or just a few more findings than the other side. I'll ask, do you sleep on that side? Well, yeah, how'd you know? It's like, well, I can tell. And that's where we will put the patients on the masks as well. We keep samples for them to try on in the clinic.
Their eyelashes are shorter on that eye too.
Yes, they are.
But you can see that from across the table. Sometimes it's like a little, dinner trick that I do. But I am such a big fan of the eye seals, that top mask, and especially in the opaque one. I like it because it is so soft, and I don't have the nose piece across the middle. But the other thing I do, Dr. Perryman, besides touching the light to the lid, as I'm coming up to the lid, I'll look for glistening of tears, just a little tiny reflection between the two lids. And sometimes that's easier for me to see than the light coming through. the other thing is that is our go-to on our questionnaire is how do your eyes feel first thing in the morning before you ever get out of bed? And people always want to say, yeah, I get up and I put tears in. I'm like, no, in bed, especially if you woke up in the middle of the night, how do they feel? And there are so many patients every single day that I find that they have a problem first thing in the morning. They wake up in the middle of the night, they're dry. And just think about what a huge leg up we have of fixing that one problem, because you should be able to wake up feeling good and then things go downhill, right? Because we all talk about the fact that if it's a closed eye environment, there is no dry eye. But the reality is they're waking up not feeling good because it wasn't a closed eye environment. And there was that wicking and just evaporation of moisture. So these things are amazing in alleviating that. And I love it because when I have a patient to me for the first time, they've got 5 different things wrong. And when this is one of them, I know I can get them relief quickly in this area, even though the other things are going to be very slow and tedious. So at least they're getting some response and some relief. The other thing I'll say is when they first come to me and they have the 5 things wrong, this is essential because they're so fragile. As they get stronger and they carry on, you know, I don't need the ointment and the mask. We can just sleep with the mask and we're fine. And they just become more defensive.
I love that milestone. It's like, you don't need to buy the ointment anymore because we've got enough restoration of all your other things and enough protection going on at night that we can skip that one now.
Mm-hmm.
Yeah, and speaking of ones flying off the shelf, Dr. Nell, this is the one that I have a hard time keeping in my clinic is the nighttime shelter because I do have a lot of patients that I identify, like you were mentioning, and it's really just such an easy add when that's not been part of the diagnosis before, and the comfort is, you know, wonderful for patients. And so, you know, they actually get very excited to call you back and tell you that they are waking up and they actually have humidity in their eyes and moisture in their eyes after wearing these to sleep.
Plus it's passive, you know, there's no effort, right? You're going to sleep. So you don't have to do a compress. You don't have to put drops in your eyes. If you can get them to fit, you just go to bed, you know, which is amazing.
And not only that, sorry.
No, that's fine.
You have to wash it every single day with a very simple soap, nothing perfumed or no triclosan, like none of that kind of stuff. Just a very simple, like a Dr. Bronner soap, because yeast and bacteria love a warm, moist environment. So you do have to wash it every morning.
Yeah. We're all so excited about it. We want to talk at once.
I know.
But this is my favorite thing. But I'll also say this, you know, I'm big on the holistic approach and, you know, diet, nutrition. We'll talk about that in a second. But lack of sleep is a big deal. And it creates a dry eye environment. We've seen it in so many different studies in animals and in people. And I love being able to give this opaque one to people who don't sleep well, because I know that it's bound to help at least a fraction of a bit. And then that's going to help me from 2 different avenues.
Mm-hmm. I also find that my patients that work, you know, night shifts, or whether they're in healthcare or working, you know, in industry or something like that, it's hard to sleep when the sun is shining. And so they actually do really love that opaque mask for, you know, to help them sleep better.
I'm going to move us forward to managing ocular surface wellness in office. So different things that you guys can do to help support that stabilization in office. Let's see, we're going to kick it off with Dr. Perriman. Do you mind?
For which one? My brain wandered.
No, that's okay. Any of these. So these are some of the things that we have up on the slide here that can be done in office to help manage the ocular surface wellness, the Sclera Lenses, punctal plugs, Procera, different
Thank you
things.
so much. Yes, so these are things that, this is a combination of things that are done in the office or they are maintained at home, but I'll just briefly go through them. Sclera lenses are an art form. Like when you have somebody who's really skilled at fitting these on patients, they're a game changer, because essentially what you're able to do is recreate the protective microenvironment that your tears are supposed to do. So in super low tear production disease states, the Sclera lenses are brilliant and super helpful. Big fan. Punctal plugs I reserve for late stage dry eye patients, autoimmune disease, etc. To me, it's never made sense to me. It's a canal that you're plugging up permanently. It's not very physiologic. There's a 2-lane feedback mechanism in the nasal lacrimal duct, and there's osmoreceptors here, so you want that system to continually sample the quality of the tears that are coming, because it makes adjustments through signals to your brain. Procera is awesome. It's a self-rotating contact lens, the amniotic membrane. I call it the Cher effect, if I could turn back time, because it soaks up all the inflammatory burden and it sends all of these youthful messages to the cells that are there, and is very, very helpful. Tear stimulation is really exciting. There's a drug in development by Oyster Point. It's a nicotinic acid spray that helps to stimulate tear production. And then this guy is the iTear 100 from Olympic Ophthalmics. We were a phase 3 clinical study site for their FDA trials. And it's an external vibrational energy. It tickles a little bit, but it does a really great job of generating a complete tear production. Autologous serum is a way to take your own blood, spin out the red blood cells, take that yellow liquid that fairly closely approximates the 1,500 plus molecules of a complete tear film. All of those fabulous growth factors, protective factors that a native lacrimal functional unit can produce to protect your eye and your cornea. When that system needs help, we can reach for autologous serum to help heal things. Conjunctival Calasius Repair, I'll be honest, I need to be more proactive in treating it. You can, I think it's underdiagnosed and undertreated. Some cases are surgical, and at least in my clinical experience, that conjunctival calasius is highly correlative with long-standing inflammation. There's something we talked about in the prior episodes is something called MMP9, which is a marker of inflammation. And that little inflammation is non-specific, but it breaks down these loose little connective fibers between the conjunctiva, or the mucous membrane of your eye, and the underlying fascia called the tenons. So when you lose those super loose connections, all of a sudden the conjunctiva looks like grandmother's old-fashioned washboard, and really what it should look like is a perfect playground slide. And so restoring that anatomically can be very helpful. You can get some shrinkage of the conjunctival folds using dilute Lumify, and that data was presented at ASCRS by Melissa Toyos a couple years ago, very exciting. And then allergy testing. This is a big deal, because if you have allergies, I just saw a patient today, significant allergies, and he's on near maximal medical therapy. He had seen the allergist, sent him to the allergist. Simple, he's allergic to cat, dust mite, and grass. Well, that's everywhere. That's ubiquitous. And so at this point, we need to start talking about immunomodulatory therapy. It's called sublingual immunotherapy, and it helps to teach your body to not be so aggressive in reacting to these allergens. It's basically relearning tolerance to common allergens. And so all these things are very important in the dry eye patient, particularly since we now have evidence that allergic conjunctivitis has an immunologic bridge to meibomian gland dysfunction, which we just talked about a couple slides ago.
Super. Thank you so much. And I know we have so many people, a huge audience out there with lots of people with lots of questions. So please be patient. We're going to try to get to them at the end. But there was just quickly, we've had 7 or so on ointments. We kind of went over that, didn't talk about it with the home treatment. And we'll probably talk about when you want to, but any comments on ointments in general for at-home use where we're talking about ocular surface?
So, I mean, the thing about the holy grail of any tear supplement is that it would stick around without blurring your vision, right? And so ointments are really good at staying on the eye for a long time and protecting the surface, but you can't see through them. And so I use them judiciously with that in mind. So if you need to be functional during the day, they're a hard sell, but at night they work really well. And some people, like if you have lanolin allergies, you have to be careful about what you use. Sometimes they can cause allergic reactions, and you might have to experiment a little bit, but they're great. The problem is they just blur your vision. So you have to miter them out a little bit.
Super. Thank you, Dr. Now. And then I'm going to ask Dr. Brimer, do you want to, I know this is an area you're really passionate about, all of you are, but managing the physiological impacts at home, that, the nutraceuticals, the exercise, all this stuff. Do you want to kick off this discussion with the panel?
do. I want to kick it off, and I'd like to talk to you about it for 3 good hours. Is that okay? And I want to send you my book, and I want to tell you all about it. But I am very convicted about this, and the reason is I converted my practice to be dry eye only because it was basically consuming the practice anyway. It was about all I did. And as I did this, I had all these very severe cases that would come to me. And let's take 2 different scenarios. One is we're doing great. We were on track, everybody's feeling good. And then all of a sudden life happens and there's stress and there's a divorce or the house is too expensive and all of a sudden they can't sleep and they're not eating well and they're not exercising and their eyes went down the toilet. And then the opposite is true where we had train wrecks come in and we're trying so hard, we're doing all these things, it should be working, why is it not working? And then all of a sudden you got a boyfriend, you know, or something else happened, a new job and things changed. And it was so much to do with outlook and lifestyle and their environment and their perspective that I literally redesigned my office, took out the optical and put in a relaxation room because I realized what an enormous effect this had on patients' outcome. And I said, I can't fix this stuff. I can't reduce their stress, but if I can just make them aware so that they have a plan, if I can give them the tools to have a plan, but make them aware so that they know they've got to be working on this for more than one reason. It's not just to feel better and to enjoy life better. It's because if I want this outcome to be better, I've got to work on everything that's, you know, leading to it because this is an end organ. And really helping them understand that it's everything in the core and the trunk that's being expressed in the eyes. And a lot of that is what we put into it. So our input, which is not just sleep and exercise and food, it's our environment of, you know, our obligations and the things that stress us and how are we managing it. So one, just as a doctor, realizing the importance of it, and that's ground zero, right? And then helping to relay that message to the patient and then realizing that importance. And then thirdly, giving them the tools. So it's one thing to say, oh yeah, you've got a problem, but it's another thing to say, here's what I've worked on to compile to give you a starting point. You go home and you read this and you read it again and you read it again. And, you know, it starts a lot with nutraceuticals. So not just supplements, but talking about diet. And what I love about this is when it comes to diet, sleep, nutrition, exercise, water, stress behavior, stress management behavior, guess what? All of those things are free. They're free. They're not an expensive in-office procedure. And a lot of times we need those. But I want you to also make sure that you're incorporating these other things because they have just as big of an impact, if not greater. So on nutraceuticals, there's a huge difference between big box stores and over-the-counter nutraceuticals and what I provide in the office or what's available from other eye care industry formulations. So they're very specific to what our end goal is. You know, when it comes to omega-3s, I need it to be the EPA and DHA. I need it to be a 3-to-1 ratio. I need it to be triglyceride form. And all of this might be foreign to you, but the point is there's a difference. So if your doctor recommends a specific nutraceutical, it's because they've seen a difference in that one versus what you can buy at the grocery store. So take heed in that. It does matter. Exercise matters. This influences your ability for stress management. It influences your overall health, your body's inflammation, which is going to be poured out in your eyes. It affects how well you sleep. And it also affects your diet because if you're exercising, you're going to be more conscientious of the diet. Sleep is huge. Not only do we have a higher prevalence of sleep disorders in dry eye patients and dry eye in sleep disorder patients, but we've seen studies where they took mice and animals and they kept them awake. And what happened to their eyes was exactly what happens in our extreme dry eye patients. The corneal degradation, everything about the tear formation being, you know, completely unnatural and not what it should be. And then they let them sleep. And it turns out that luckily it was reversible. And so the point is sleep matters. And that if you are a dry eye patient, you've got to be aware of your sleep because there is a correlation there. Diet and nutrition, there are inflammatory foods and there's anti-inflammatory foods. Not only that, but you may have a hypersensitivity in your body to certain foods. when I do the allergy testing, like Dr. Perryman talked about, 8 of my 80 things are foods, and I love it. Today we did one, and one of the biggest reaction on this fella was wheat. What an amazing discovery to find, even though he didn't know, realize the GI issues of it. If there's a hypersensitivity there, it can be affecting our outcomes. When we discover that, then not only are we going to help his eyes, but we're going to help other things in his body and just the way he feels and his fatigue and inflammation and other things. So diet, nutrition, I've collected a lot of information, like, 30 ways to get better sleep, 30 ways to handle stress, things like that, foods that you need to look for. But the thing is, I did a lot of it by research online. And so you can find that information too if your doctor doesn't have it to hand to you. One of the good resources for nutrition is the Arthritis Foundation. You can find a wonderful diet there, and it shows you, each food group, what to look for, what its benefits are, the easiest ways to get it. Water intake is huge. There's a direct correlation, no, indirect correlation. The more water you drink, the fewer dry eye symptoms you have. And there's other things that go into that, but that's one of the things you can do at home that's free, and you can do it immediately. And then again, stress management, anxiety management, depression, all these things, not only do they create inflammation in the body and open up these neural pathways to allow you to feel more pain, it also affects whether you want to do your routine. And if these things make you less compliant, then it's going to negatively affect our outcome in that way as well. Screen time is huge. So when we talk about behavior, it's not just device use, which especially during COVID is a huge thing because everybody's at home more. They're on their device more. When they're out, they're with the mask. And especially combining those two is big. But not only that, it's also talking about things that you're exposed to. So this could be partial blinks. This could be smoking, different things, wearing a lot of perfumes, being in a moldy environment, just everything that's around you that could be influencing. And then finally, the things that you're putting on your skin. I talked to somebody just today about the potential to have hypersensitivities and that we needed to go all free and clear everywhere in their world, not just laundry detergent, but the hand soaps, the fragrances, the lotions, and just start from scratch. So this is a little bit overwhelming to think about all these little things that could be influencing your dry eye outcome. But I don't want you to see it as overwhelming. I want you to see it as encouraging, because these are things that tonight you can sit down and say, what is my score? How do I rank on this? And how can I make this better tonight before I ever even go back and see my doctor? That was a lot. So what do you guys think?
Any other comments? I know there's been a lot of questions. We have a lot of Sjogren's patients in the audience, a lot of people that have questions about using makeup and whether or not, if they have chronic dry eye, whether they should be using makeup. Dr. Now, you have some comments?
So makeup, lots of makeup is super toxic. We don't throw away our makeup. We don't wash our brushes. You must clean it off at night if you're going. Imagine a situation where you're staring at a computer all day, a sedentary lifestyle, maybe you're dehydrated and you sleep with your eyes open and then you don't take your makeup off, And so it's like these little things, they build up. And look, I wear makeup. I like that. It's fun to get dressed up and look pretty. We're not saying don't. We're saying do it smart, Try to find products that don't have formaldehyde in them. Credo, CREDO.com is a company that they curate non-toxic products. There's a lot of different things out there. So yeah, wear it, but maybe if you're home and you're not doing anything, don't wear it. Give your eyes a break, especially if they're dry and they're hurting.
Bill and I did a study and we presented at ARVO in 2017 where we sent out a questionnaire to over 200 participants, and we found that symptom scores, we talked about symptom scores previously in the Tranquilize research, is much higher in patients who don't remove their makeup every night. So there's definitely that component of prolonged exposure, possible bacterial component to all that as well. So I'm glad you pointed out the fact that maybe skipping some days is a good idea and being sure to remove it at night is helpful as well. With some of the the foams that are provided by Eco are very effective at removing makeup.
And I'd give a shout out also just to fake eyelashes, which they're really popular. And just in the last month, I've seen 3 patients who've had pretty profound allergic reactions to some of the adhesive that's on there. So if you do get false eyelashes, just, if you're having problems, you may want to ask whoever does it, what kind of adhesive are you using, or switch, or just take a break from them, every once in a while, because if you have those on, you also can't really clean your lashes without ruining them. So, intermittently take a break. And I tell my patients, look, if you're going to be between lashes, come in and we'll do a comprehensive eyelid cleaning. We'll get rid of all those Demodex. We'll, really clean you up so that when you go in for another one, you're not putting something that's already kind of dirty. So it'll look better. Your eyelashes will like you for doing that.
Not only the cleaning effect with the eyelash extensions, but whenever you have an abnormal eyelash length to lid length ratio, you actually end up disrupting the normal wind deflecting power of the lashes, the normal allergen deflecting power of the lashes, the normal evaporation protective attributes of the lashes. And this was done in this awesome study, 22 different mammalian species, that there's an ideal lid lash length to lid length ratio that's designed to maximally deflect wind, debris, and evaporation stresses from the eyes. So every time you do that, you're compromising your own protective mechanisms against dry eye, evaporation, and allergens.
Super. Thank you so much. We're going to move it along. Sorry to cut this, such a great conversation. But what about in office? What can we do in office? I know there's been also a lot of questions between differences between Restasis and the other ones that are out, the prescription drugs. When are they appropriate? When aren't they? And I know we're going to get into that for the treatment, but maybe kind of a general overview of what's available for prescription office, Dr. Now.
So I think a good way to think about it as a patient is that you should have home therapy, but dry eye causes inflammation. And sometimes you need just a short-term pulse. And those are usually things that are called steroids. They're not necessarily safe to keep using because they do have some dangerous side effects, but those are great short-term type of things. If you have more established inflammation, which we can pick up on like the osmolarity test and the MMP9 test, if those are consistently positive, it means that you can't get ahead of the game. And so you need some help to do that. And that's when you reach for the steroid sparing agents, like you'll hear of Restasis, Xiidra, Cequa, which is just a stronger dose of Restasis. And those try to blunt the immune response. And so they're helpful for ocular surface inflammation, but also eyelid inflammation. That drop is going not only on the surface of the eye, but it's getting inside the lid. And that can really help as well to calm down everything. And then the third class are biologics. And biologics are things like serum drops or amniotic fluid drops. And we tend to use those when we know that the cornea is inflamed, because there's multiple peer-reviewed publications that shows that the nerve cells actually normalize once you've been on serum drops for 6 months or a year, and it can take some time. So we try to personalize that based on point of care testing, and sometimes we use them together. So you might need an anti-inflammatory and a biologic, so we try to really curate it for each individual person, but base it on data that we collect in the exam, which is kind of what we were talking about last time. But they're very powerful, and unfortunately, sometimes they're not covered by insurance, and that can be a big burden. And I do have some patients who can't afford to do those things. But we try to minimize medicine, and we try to do as much as we can without it. But we definitely use it every single day when it's needed.
Super. Any other comments on the prescriptions? I know we'll probably get into differences or difference between them. Yep, Dr. Perrin?
I totally agree with Dr. Now that all these things have their role and they're important. The mistake that I often see amongst our patients is they will think, I'm not feeling any better, so they quit. And that's really unfortunate, because as Dr. Now said, we get these actual microanatomic improvements in the corneal nerves with cephalosporin therapy, restasis, beautiful paper in 2017 with our autologous serum tears. And we really need to recreate as normal of a microanatomy as possible. That normalization of the corneal nerves is yet another piece in creating restoration of the entire lacrimal functional unit. So if your doctor's decided that you would benefit from one of these prescription anti-inflammatories, I would highly encourage you to stick with it, because there are long-term microanatomic improvements that happen over time. We'll get you feeling better eventually, but we also need that normalization of the wonderful anatomy that Mother Nature created.
Great feedback. Oh, go ahead, sorry.
I was just going to say one misunderstanding that we often run into is that people sometimes erroneously think that just because they take a medicine that's enough. But I think as a patient, if you look back to the beginning of this lecture when we were talking about the need for, taking care of your lids, or the need for lifestyle modifications, restasis won't make you feel better if you're up all night and you don't drink water, so it only can go so far. So it has to be the whole comprehensive package, or it's not likely to succeed.
That's a perfect segue into the second half of the evening, and I know this is an area that's important. So now the patient, these are all some incredible tools both at home and in office, and now it's marrying of, I've walked out of my doctor's practice, or I've just been diagnosed, I'm sitting in there in the office and they've told me I have MGD, what do I do? So the second half of this evening, or the rest of the time we have here, is going to go through taking these menu items that you've just seen, and what doctors, these beautiful experts, would say about what to do if you had, for example, meibomian gland dysfunction. How can you help treat that at home and in office? And Dr. Odell, I know we only have a few more minutes with you, 10 minutes or so, but you want to kick this one off with the panel and kind of share some insights about at home and in office treatments for MGD, both mild, moderate, and severe?
Of course. So for me, with meibomian gland dysfunction, first of all, it's getting that diagnosis, because sometimes I feel like it can be a mis or underdiagnosed condition. And so I like to do that in my practice, not only by looking at the structure of the meibomian glands and imaging them with meibography images, but I also like to, know how they are functioning. And I do that actually using a tool that helps me look at the expressibility, or what's being released from those glands. So I think that's important to make sure that you have a good diagnosis that's looking at the structure and the function. And then being diagnosed with mild, moderate, or severe disease does help us, and that's why there's such a great product line available for moist at-home heat through IECO. If I do in fact have a mild patient, that is where a derm mask for me would fit a great, at-home care for a patient. I do look at that as 5 to 10 minutes still with the heat mask, but it's good to see that, duration. And I would definitely start having that conversation about any kind of environmental factors that we can change, managing screen time. Maybe, managing screen time, I think, becomes a challenge right now. I think teaching our patients, like we spoke to earlier in another one of these series, how to blink and how to take breaks, blink breaks during computer use, is going to be a better way to go about that in the environment we are right now. But then when I start to have these moderate to severe, I definitely lean a lot on my at-home therapies. And I think that if I have patients that are doing the Tranquil Eyes or Tranquil Vibes or iCloud at home consistently, 20 minutes of daily heat, and then I'm coming in, they're coming into the office to do a manual gland expression, or, we're signing up to do a glare and clearing treatment with LipiFlow or Tear Care or iLux or IPL, it's going to make my treatment so much more effective. So I really like to pre-treat my patients, using at-home therapies ahead as much as I can of when I'm going to do that treatment in the office. And then again, once my treatment in the office is done, sending you home again with that continued heat, just to try to maintain gland health. And then I guess, I would just say the diet and nutraceuticals is a big component that I think, we should continue to touch on, because like we said, if you're not hydrated, it's going to be an uphill battle. We are what we eat. So when your diet is pro-inflammatory, we're just fueling the fire of inflammation. We know dry eye and meibomian gland disease has inflammation at the foundation.
Super. Any other comments on this one? It's a big one. Okay, then we're going to go on to, let's see, Dr. Brimer, do you have some thoughts about how you would treat blepharitis versus Demodex, both at home and in the office?
Yes, I
The rest of the panel. Thanks.
I do. So the heat is helpful, but I think it really comes down to cleaning and killing. Now, which soaps and treatments that I go to when it's blepharitis versus Demodex might be a little bit different. And just for the audience, the difference between blepharitis and Demodex, if I'm looking at the lashes and I see more like dandruff-like debris up in the lashes, then it's going to be your run-of-the-mill garden variety bacteria blepharitis. Demodex is very specific, and it's going to present as a collarette, like a little collar around the base of the lash. And that's because we believe the mite's down in the follicle, and as it grows out, that's supposed to be the tail around the base of that lash. So those are much more stubborn. So that's why you see a longer list on the Demodex side, because it takes more to kill them and to really get them to let go and come to the surface. So any blepharitis, any lid bacteria, I want to do heat, but I really want to focus on cleansing. I love my iEco foam soaps. So that's my go-to for just basic and anyone. And I have tea tree oil in all of those. When it's Demodex, I might go with a stronger tea tree concentration, and I might go with a more mechanical approach. So that's when I might do the new lids. Now it's listed here in office, but it's actually an at-home device. You can do it in the office, but then you can take it home and do it every single day. So the difference between blepharitis and Demodex, I'm going to need more advanced, more aggression in really getting control of it. So I'm going to still use my cleansers. I might go up to increase the concentration of the tea tree oil, and I might add in some mechanical cleansing at home. Avoid ointments or avoid makeup, add ointments. And this is where, like Dr. Perryman was talking about earlier, of topical antibiotics being helpful. That would be the case in both of them. There's some places, some folks where I'll prescribe a liquid antibiotic to put on the lid margin, but most of the time it's really just about cleaning. It's not so much about needing an antibiotic on top of it. Now, as far as in-office treatments, IPL is fantastic for going into the skin, killing the bacteria and the mites that we believe drive the inflammation. So that same little mite that is Demodex and it's found in the lashes is also found in the skin. And a lot of times it's that skin presence that's driving the effect and the presence in the eyelashes. So if you are a patient with acne rosacea, and you've got pink cheeks, they flare up whenever you drink red wine or you have spicy foods, hot beverages, you're in the heat, you're in the cold, then you've got acne rosacea. If you see those little blood vessels around the nose or anywhere on the face, that's acne rosacea. So this is the same mite that's responsible for that is responsible for, or that is Demodex in the lashes. So IPL works wonders in controlling that. And when we use it, we're really kind of treating the tree trunk instead of just the branches that are the eyes. So I say the face is like the trunk, the eyes are like the branches, and I want to get to the root of it. And really, I can use that with any degree of blepharitis, but especially with Demodex. What do you guys think as far as your go-tos and the difference between them?
Dr. Perriman?
Does that pretty much sum it up?
There you go. That's a pretty good one. Okay. You know what? We'll in the.
I love IPL for all of these things. There's IPL has been shown in the peer-reviewed literature to be effective against facial rosacea. We published a paper in January showing Demodex on an eyelash can be destroyed with IPL. You can actually also treat conditions like seborrheic dermatitis, which is a common, commonly missed component of blepharitis and meibomian gland dysfunction. So I love all these tools, and I find them to be very effective. I would say that I haven't played around with oral ivermectin very much. I know there's a topical form called Soolantra, Soolantra. that's pricey, but you can sometimes get co-payment coupons for it, or you can get it, I think there's generic alternatives, or some physicians can have it custom made for their offices. So there's all kinds of different aspects to Demodex. There's a drug in just started phase 3 FDA development that is actually kills the Demodex, and it's based off of veterinary medicine, and now they're looking at it for human use. So I think that all of these things are great tools, and they are effective. I've got multiple examples in my case series and my photos showing the benefits of all of these things, and they all work together.
And we're going to show those in a minute. I'm going to move right along because it goes back to we have so much to cover. So another area here of I've been diagnosed with Sjogren's, for example. What do I do? What can I do at home or in office? And recurrent corneal erosions is another one we hear a lot of. Dr. Pearman, you want to expand on those?
Sure. So the Sjogren's patient is a severe dry eye patient, and they're dealing with not only impacts on their eyes, but other aspects of their body as well. And so we're always trying to help them holistically. And there's approaches for helping that component as well. But it's with the Sjogren's syndrome patient, it's yes and. So it's usually you're doing all of these things to help keep it under control, and they all do help. They all work together. It's a matter of piling on enough treatment until we can get you to a more comfortable place, and then maintaining you there and hopefully simplifying your regimen over time. Recurrent corneal erosion, Miro 128. I actually don't think that's the best use of Miro, honestly, because it's a high salt ointment, and salt is an independent driver of inflammation. So recurrent corneal erosion, as a cornea specialist, is better served by methods to decrease inflammation, all the things we've talked about, all the MGD in office, at home, your prescription pharmaceuticals, and then also sometimes a in-office procedure where we remove the sick epithelium and then place a amniotic membrane of Procera. That's, in my hands, is far more effective than Miro ointment. But that's just another treatment option. All of these things are important components to it. In the office, sometimes we'll do a test dose for the Sjogren's patient to assess tolerability to the prescription drops for Restasis hydrocequa, but oftentimes the Sjogren's patient they're just too raw. There's just too much inflammation to tolerate the easy things like prescription drugs. And so for those, what we'll do is we'll throw them a lifeline, so to speak, and pull them up out of the inflammatory abyss with systemic treatment, with Procera rings, with autologous serum. And after about 6 months of that real intensive rehabilitation, they can often tolerate the easy things, such as prescription Restasis hydrocequa, much better. We do all these things. The scleral contacts are very helpful in recreating that microprotective environment for the cornea, the job that your healthy tear film is supposed to do, but needs a little help because it can't do the job it needs to do to protect your cornea. So yeah, I'm a big fan of all these procedures.
Super. And then another big area, and we've had a lot of interest here too, like these are some of the things that you would diagnose when you're talking about evaporative stress. What about Dr. Now, do you want to share some insights on how you would go about treating these?
Yeah, so we touched quite a bit on this a few slides ago, so I don't want to rehash that too much. But other than to say, this is actually really common. I mean, we did a study of 175 patients presenting for primary eye care exams in our office, and 65% of them had poor lid seal. And there's, I think it was half of those, maybe 52% of those had severe morning symptoms. So if you have symptoms of dryness or stickiness of your eyes, tell your eye doctor about it, because this is a really easy thing to fix. So a lot of times we'll give just a fabric sleep mask, that you get on an airplane. And so sometimes that's enough just to kind of keep your eyes shut enough. If those don't work, then we'll go to the eye seals. A lot of the success depends on your facial configuration. So if you have very deep set eyes or, a larger bridge, sometimes it can be hard to get that good seal, and we have to work around that a little bit. But if you're persistent and if you can fix this problem, I think it's probably equal to a medication. it's very effective. And I don't really think that you can feel a lot better if you can't tackle this. And then talk to your doctor about surgical repair, because if you've got really floppy lids, or like Dr. Perriman was saying, your eyes are saggy, or there's just a lot of overage skin, you won't ever be able to get your eyes closed really well. So you can ask for a surgical consult for that.
Super.
Helps
Thank you
tremendously.
so much. Another big area, and then actually further over on the right-hand side, ocular allergies and ocular rosacea. We've got tons of people that are asking about how would you go about treating that. And Dr. Perriman, I know this is a big interest to you also, and Dr. Brimer, you touched on it earlier. So Dr. Perriman, do you want to share some insights how you would handle the treatments of those in office at home?
This is for allergy, you said?
Yeah, either ocular allergies and ocular rosacea. Those two are the ones that are coming in for the Q&A section with great scores.
Those are two very common topics, right? Ocular rosacea and ocular allergy. Given the fact that we now know that allergic conjunctivitis is an independent driver of meibomian gland dysfunction, there's an immunologic bridge that keeps driving it. Knowing that has made me even more proactive in addressing ocular allergy. And sometimes it's subtle, and sometimes it's just a little hint of something on exam. And if I see that, I'll take one of my prescription sample topical anti-allergy drops. I keep Pazeo in the clinic, Bepreve and Zerviate samples in the clinic, and I'll just put a drop in one eye. Still talking to the patient, still doing my exam, and I'll ask them at 3 minutes, which eye feels better. And if they say this one is smoother and feels better, I know there's a smoldering allergic process going on that I have to address. And so that's essentially addressing a problem at the source. And I think that's a mindset that everybody on this panel certainly embraces, is to identify as many contributors and co-conspirators to your dry eye disease as we possibly can and address them at the source. So I think that's an important part of it. As far as ocular rosacea goes, I'm a huge fan of intense pulse light therapy for that. We do an aggressive full face treatment with corneal shields behind the lids to protect the eye. And we see really encouraging, really exciting improvements in that particular driver of meibomian gland dysfunction. You'll notice that as your ocular rosacea comes under control with your IPL, that things like your heat masks are even more comfortable and even more effective at maintaining that liquid meibum.
I would just add to that, Dr. Perriman, I cannot say enough about the saline rinse. I mean, we're talking about a $5 bottle of eye wash, and I have patients who just swear by it, because this allergy patient is the patient that I'm looking at on my 5M, and I see, or my slit lamp, and I see so much tear film debris. It's quite offensive, and especially when you show it to them, they're incredibly offended by it. And that's what's driving some of their discomfort, and it's there because of the allergic response. So sometimes instead of a big expensive tear or even a prescription drop, they can get just as much benefit from a good 5-second rinse, full power rinse from a bottle of eye wash. I don't like using the cup because it doesn't get down in the folds that we keep talking about and how all this stuff is hiding there. So I love the saline rinse, followed by, the antihistamine drop like you spoke of. But the one thing I feel like is missing here is the sublingual immunotherapy that you were talking about earlier. So patients don't have to go and choose between antihistamines that will dry them out and going to get allergy shots weekly at an allergist office. There is another option, which is that sublingual immunotherapy that builds their tolerance to it. So I love that. Love the IPL for my rosacea folks.
Nice.
And then Dr. Now, do you want to chime in maybe on the styes and chalazion?
So yeah, I mean, if you guys start to feel a little something in your lid, compress 15 minutes 4 times a day and keep it clean. And most of the time they go away. But sometimes they don't, and sometimes they stick around for a long, long time, and it's uncomfortable, and maybe you can't wear your contact lens. But the first line therapy is really to hit it with heat. Don't burn your lid. I mean, that's not going to be helpful. And if it doesn't go away in a few days, call your doctor. And then we have a lot of antibiotic ointments and steroids we can use. IPL works really well for that. We do manual heated expressions for styes. So if you can kind of pop it, I mean, essentially that's a pimple. And so we can help you with it. If it doesn't go away, you can always get them excised. But I think in the last 2 years, I maybe have sent 3 people for an excision of a stye. So we really do have effective ways to tackle them now. And I think IPLs are really great. Just, one shot with that does also help.
Super.
And I would add to that, Dr. Now, is that a lot of patients end up in my office, and it's not because they're uncomfortable or they have what they think is dry eyes. It's because they have chronic styes. So as a patient, if you're getting these, even 2 or 3 a year, that's not really normal. You've got an underlying condition that is predisposing you to this. So go to your eye doctor, tell them, hey, even though they went away, these keep coming back. Is there something I can do to prevent it? Because for your long-term outcome, you want to be on the preventive side and not the reactive side. Because every time you get a stye or chalazion, you risk losing that gland altogether and then having a much different outcome 10 years from now than you could have had otherwise.
That's a great point.
We presented some work at Ascaris and again at Women in Ophthalmology using a specific IPL protocol for specifically addressing chalasia, acute and chronic chalasia. It's called the Perryman protocol. I sheepishly admit that, but that's what it's called. And I'm so happy. I hope it works for you. That's awesome. But we just got we're just finishing up our IRB approval to actually study it. So we'll have some scientific publications for you, I hope, in the very near future.
Super. Wonderful. And then any other comments on inflammation? I think we've covered a lot of inflammation, and I know that's a big topic in itself. But I think any other additional comments if you see inflammation in addition to
Well, I think just maybe a comment is that everything in your body is connected, and the eyes are kind of like a canary in the coal mine, and if they're really bothering you, it's not just your dry eye. Usually there's some other environmental component, lifestyle component, diet component. So just pay attention to that because it makes a huge difference. Pro-inflammatory lifestyles damage all of your body, including your eyes.
Wow, great.
The other thing I'd like to add is just because your eyes are not red does not mean there's not inflammation. Redness is just one small part of inflammation. So even if your eyes are white, don't assume there's no inflammation there.
Interesting. And then Dr. Perriman, you provided these beautiful photos of before and afters and things. Any comments that you want to just point out of things that you can that I think
Sure. So I'll start with the bottom row because my little Zoom thumbnail thing's in the way of the top row. So I'm going to start at the bottom row. And what this is showing on the lower left corner is a patient a dry patient who called me in a little bit of a panic because he was headed for his dream job interview in 2 days. And he had this. So I said, well, come on in, let's have a look. And it was just an inflamed mess. There was nothing there to incise and drain. And I didn't want to do a steroid injection because he has a rich pigment to his skin and you run the risk of hypopigmentation. So I said, really your best option is IPL. And he sends me this picture the day after his interview. And then he sent me one at day 5 and he says, and I also got the job. So that's kind of awesome. And so it really helped him get over this lesion. The next picture is a person with recurrent chalazion that Dr. Brimer was talking about, gets them all the time. But the number and the frequency is going down because we're doing these IPL treatments for him. And you can see that there's an immediate effect in the redness, the swelling. Patients will say, oh, it's so much less tender, and I can see that it's less swollen, so that you do get an immediate effect. And this next picture, this poor person was so needle phobic, if you even said the word needle, he would break into a cold sweat. So there was absolutely no way I was going to be able to do any kind of surgical intervention on his chronic chalazion. And 2 large ones resolved within 6 weeks. And then the last one this is a patient who had this lesion cut into twice, so had 2 surgical procedures, and it's still there. With 1 IPL treatment, it completely resolved within 2 weeks, and we tracked the inflammation load, the MMP9, and it dropped to negative within 2 weeks with just 1 treatment. So it's an exciting project. Does it work 100% of the time? No, but it's a certainly helpful alternative to needles, drops, and surgical maneuvers. And you get to preserve the anatomy. Like Dr. Brimer was saying, that like every meibomian gland is important, and we want potentially saving one may have an impact down the road.
Got it.
So the macro just shows.
Oh, sorry.
Oh, sorry.
I'm sorry. I wish we were running out of time here because we promised to have Q&A here for 10, actually 15 minutes, and we're down to 7. So I'm just going to pop, if you don't mind, I'm going to go to the audience Q&A. This was an interesting one. Do you, and maybe Dr. Brimer, you have some thoughts on this. Have you ever seen dry eye causing migraines, or is there an association between migraines and dry eye?
Boy, that's an interesting one. I have had a handful of patients who migraine was their primary concern, or somehow it's how they ended up to me. But I would say as I look at my patient base, I don't see a huge correlation between it. But you think about the things that drive dry eye and the things that drive migraine and systemic inflammation and so many other things, including stress and anxiety and all this, can be drivers of both. And maybe, Dr. Brimer, maybe you've got a more scientific answer there. I've had more patients who had both. I just haven't had a ton who that was a primary concern with them or primary complaint.
Okay, and then
so there's been some description in the literature about the association between migraine headaches and dry eye, just and also recently sleep disturbances and dry eye. So I think, to your point, that it's all connected. Like there's this neurological connection to all of it. Even depression is associated with dry eye, possibly from just generalized slowing of the nervous system and the neural impulses. So you're absolutely right that there's connections with all of these components with dry eye.
Super. Here's another one that's been frequently asked. It came up actually in episode 2 about the preservative for eye drops, preservative versus non-preservative. And if you are using preservative because they are less expensive, how much is too much? Dr. Now, you want to?
We kind of cap it out at 4 drops a day, with preservatives. And if it's more than that, you should do non-preserved. And this becomes an issue with patients who, have on glaucoma medicines, and you have to be really careful so that you're not overloading them with preservatives. So yeah, we try to limit them.
Okay, very good. Let's see, fibromyalgia, we did that one the last time. Oh my God, there's so many questions. Omegas, people are asking about, do omega-3, 5, 7 really work? And if so, can you make some recommendations of which ones, or which ones you all favor?
Short answer, I favor PRN for omega-3 and science-based health Hydro Eyes for omega-6. A lot of patients, I'll use them together. I choose which one to start them on based on their diet, their deficiencies, and how much systemic inflammation they have. Just because there's more research behind the omega-3s and the systemic benefits, it doesn't mean they're not there in that Hydro Eyes. But if I need more systemic, I'm going to start with the omega-3. Every time they come in, I'm going to squeeze. If it's still thick, what's coming out, I'm going to add the 6 and use them together as a dual mechanism of action. It works great.
Great. Dr. Perriman, another question. Is there a protocol for a person with TED who has severe dry eye who needs cataract surgery? I think we touched on this last time. Yeah,
graft versus host disease?
Yeah.
Graft versus host disease that needs cataract surgery. That's a tough situation. Those are actually level 4 dry eye patients, and you have to proceed with great caution because a lot of the protective mechanisms are significantly compromised, and that's a tough clinical situation. And yeah, you can have cataract surgery. Just proceed cautiously and do everything you can to optimize that surface beforehand, because we know that even in patients without graft versus host disease, that blepharitis and meibomian gland dysfunction get worse after cataract surgery. And the more you pay attention and optimize it before the fact, the more successful you'll be after surgery.
Okay, here's another one. Dr. Now, do you have thoughts for people that using a hot compress if you have rosacea? You know, 'cause
So,
heat and rosacea.
yeah. So, you know, I think that you have to balance it. If you, some people need hot compresses, but if you have a reaction to it, if your lids get inflamed, it's not for you. And then you have to rely on office treatments for doing that. So proceed with caution, I guess. But I have a lot of rosacea patients who use warm compresses successfully. So I would say just make sure that you don't make them too hot.
Okay, very good. Oh boy, three requests. Demonstration on how to properly blink. Oh, excellent one. Okay, how about each of you individually? We'll start with you, Dr. Perriman. Proper blinking. What does that look like? Maybe you can go straight to her again.
No, that's a wink. Sorry. I'm going to pass this on to my colleagues. I think they're better teachers at it than me. I just don't want patients being aggressive with it. I just want them to close, but that squeezing, that real aggressive isn't good. So I'll let my colleagues take it away.
So I'll get close, and I would say this. This is my normal blink. When I concentrate, I'm just making sure I'm going down all the way, but I don't concentrate on it as much as I do my blink exercises. So I close, and then I'm pulsating. So I don't know if you can see it, but I can feel it in these muscles. I am not using my forehead and doing that. Why? Because it causes wrinkles. I don't want that. I got enough of those. So don't use your forehead. We're trying to create muscle memory here. It's just like when you're learning how to sit up straight. It's obnoxious, it feels uncomfortable, and you're having to remind yourself constantly until all of a sudden it doesn't feel uncomfortable. It's normal for you because you've got new muscle memory. And that's what we want with those eyelids. So you're really just trying to make sure they're coming down all the way, especially when you're concentrating. When you're watching TV, you're staring at the computer, you're staring at your phone. We have a propensity to blink much less frequently. It goes from like 18 times a minute to 4 times a minute, and then more partial blinks. So those are the times you really want to concentrate on the blink exercises, and then that's going to reform your blink and make it more of a habit to go all the way down.
Super. Dr. Now, I know this is a big part of your protocol. Anything to add to that?
I think just, you don't want to engage these muscles here. So if you look at the structure of the eyelids and you look at how muscles encircle each of the meibomian glands, you have to engage the eyelid muscles to properly squeeze the glands, expel the contents. And then the other thing that we didn't talk about, but it's true, is that there's a reservoir of tears behind the lower lid. And in order to drag that reservoir of tears up onto the ocular surface, you need to execute a full blink. So I would just say slow, deliberate blink. The eyelid should touch. Don't engage your face, and do it frequently throughout the day.
Oh, I can't believe we're here. Okay, it's 6:30, 6:31. You are amazing. Thank you, everybody. I know there's like 500 more questions, and we will get to them. We will get into answers out to you, but thank you for being here. Thank you, doctors, for a wonderful episode 3 and for your gift that you give every day to dry eye patients. And I'm just honored to be here with you. And I wish you a very, very happy holiday. I can't believe it's December 1st.
We made it.
Thank you so much. Yeah, thank you. Enjoy your evening, everybody. Thanks for being
Thank you.
here.
Thank you. Good night.
Good night.